So good morning, guys. So let's continue the same type of discussion in today's class as well. So this is clinical cases discussion part 8. And I have mainly compiled the question from our medical quiz. Okay, this time because many students they have not participated in the quiz, and some of the students they have actively participated, but it was a bit long time ago. So let's revise, because that time I have compiled those questions from a lot of sources. So it is a good opportunity for us to revise or to practice those clinical cases once again. Let's start. Now, see here, the parasite which is shown here in the picture. Okay, there is a small horn-like structure at the end of the egg of this parasite, enters into the body through penetration, causes hematuria, and later it may lead to development of squamous cell carcinoma of the urinary bladder. These are the very important clues given to you, okay, regarding this particular parasite. Identify the parasite by this clinical clue and looking at the picture. Yes?
Cystostoma hematobium.
Cystosoma hematobium. Cystosoma hematobium. Absolutely
Yes.
correct. Very good. So this is cystosoma hematobium. Because this typical picture, it enters into the body through penetration. It causes problem in the urinary bladder, and in the long run, squamous cell carcinoma of the urinary bladder is developed by a cystosoma hematobium. Now, a little bit of more information. The most common malignancy of urinary bladder is transitional cell carcinoma. Transitional cell carcinoma, because the epithelium of urinary bladder is transitional cell epithelium, and smoking is one of the most common cause for that. Okay, remember this. Whereas uh, this squamous cell carcinoma occurs if there is chronic irritation or chronic infection which is going on inside the urinary bladder. This is because of metaplasia of that transitional epithelium towards the squamous epithelium, and cystosoma hematobium is one of that organism. Now, some more information. There are other species of cystosoma as well, like japonicum and mansoni. This cystosoma japonicum and cystosoma mansoni, they usually causes portal vein infection, or they may cause problem in the portal vein, and by doing so they can cause portal hypertension. So these are other important questions which may be asked to you in your future exam. Let's move on. Okay, now see that the answer is cystosoma hematobium. Now number 2, this is karyotyping of a patient who is having massive splenomegaly. So look at this, karyotyping and tell me the diagnosis.
It's CML.
Sir,
Yeah?
it's
CML.
Philadelphia chromosome 922 translocation
Very
associated
good.
with CMS.
So this is translocation between chromosome number 9, which you can see here by arrow, chromosome number 9, and chromosome number 22. So 9 and 22 translocation. This is Philadelphia chromosome. It is also known as BCR-ABL fusion. Okay, another term for Philadelphia chromosome. Actually, this some material from the chromosome number 22 will move and attach on the chromosome number 9, and this chromosome number 22 will look very shorter than the normal, and this actually is called Philadelphia chromosome, the chromosome number 9. Now, in these cases, okay, uh, uh, this Philadelphia chromosome can be present in so many other conditions, but the most important one, always remember this, whenever your teacher asks, the first diagnosis is chronic myeloid leukemia, CML. It may be present in other condition like AML or very rarely in ALL as well. And when it is present in those conditions, the prognosis is usually poor. And at the same time, your teacher may want to ask you about the causes of massive splenomegaly, which we have recently talked in 1 or 2 lectures, before. Chronic malaria, chronic Kala-Azar, okay, portal hypertension, chronic myeloid leukemia, which we are discussing now, and then lipid storage disorder. These are the common causes. So see that Philadelphia chromosome, which is specifics of CML. Now, question number 3. This is a 45-year-old male. Okay, the age is 45 year. Okay, and that male presented with blood pressure of 180 over 110. 180 over 110. So this is hypertension. His father was also suffering from hypertension. Look at this, picture and tell me the diagnosis.
Autosomal dominant polycystic kidney disease.
Autosomal dominant polycystic kidney disease. Can you please explain?
Sir, autosomal dominant commonly occur in adults, means in polycystic kidney disease. So due to this, hypertension in both father and son.
Good. So he's saying it correctly. This is autosomal dominant, nature, because father was also having the same problem and the son is also having. So this is very likely in autosomal dominant, type of inheritance. Blood pressure is high, and look at the, kidney. See, these are the multiple cysts which are present in the kidney. This is a cross section of the kidney, though. Okay, so all of these, if we combine together, the diagnosis is no doubt polycystic kidney disease, autosomal dominant one. Now, a bit of more information here, okay? That's why I have collected these cases actually, so that we can discuss something more here. This disease is very interesting in the sense that till the age of 45 to 50, this patient is asymptomatic, doesn't have any symptom, though kidneys are like that. The reason behind is there are a lot of normal nephrons still present in this type of kidney. That's why the person is still maintaining the kidney function. Okay. Now, when the nephron number is decreasing, or decreased to a substantial amount, then only there is a defect in the kidney function, which results in increase in blood pressure and other problem. That is number 1 point. Number 2, apart from kidney, other organs are also having cyst, similar type of cyst in this disorder. And those organs are liver, sometimes even pancreas, and sometimes brain is having some problem. What is that problem in the brain?
Berry aneurysm.
Excellent. Berry aneurysm in the brain. Very good. Berry aneurysm. And those berry aneurysm can rupture and lead to subarachnoid hemorrhage. Subarachnoid hemorrhage. So these are some associated questions regarding this autosomal dominant polycystic kidney disease. So which antihypertensive drug you want to give to this patient now? Yes, how do you want to treat this case? Anybody? Okay, the answer is most probably this patient is also having proteinuria. Proteinuria is common along with hypertension. So AC inhibitors are important drug in this case. AC inhibitor. But remember one important point. I should always do kidney function test or renal function test before start AC inhibitor. If the kidney function tests are very abnormal, then probably AC inhibitors are withheld and I should use some other drugs. Now, this is a straightforward question. Okay, see here, Gaucher disease, an inherited human disease. This is autosomal recessive disorder now. That's why it is written like that. Resulting from abnormal accumulation of membrane lipid is caused due to the deficiency of which of the following enzyme? Is it hexosaminidase A? Is it alpha galactosidase A? It is glucocerebrosidase, sphingomyelinase, or galactosylceramidase? Which is the answer here? It is C.
C.
Okay, very good. Glucocerebrosidase. So what is the thing I'm telling you here is, please, if you have time, go through any biochemistry textbook and correlate between this lipid storage disorder and the deficient enzyme. Okay, make a note of it. Sometimes the question may be asked like that. Now, Gaucher disease is such a type of disease, especially in pediatric age group. It manifests in pediatric age group that a lot of organs are infiltrated by these abnormal lipids. Okay, and because of this, mainly the central nervous system and reticuloendothelial system are affected. So the child will have regression of developmental milestone. Now, what do you mean by that? Regression
It's sir,
of development. Yes, yes, please.
sir. It means that if a child knows how to walk and how to draw, so after this disease diagnosis or occurrence of this disease, so he will forget the previously learned thing.
Very good. Very well explained. Exactly like that. The child has already learned some of the developmental milestone, but after this disease occurs, the child will not be able to fulfill those developmental skills once again. The child forgets. The child will go back according to the developmental milestone. This is called regression of development. This is one of the very important feature of a lipid storage disorder like Gaucher and Niemann-Pick disease. And this disease also have massive hepatosplenomegaly and lymphadenopathy as well. And diagnosis is done by bone marrow analysis. Now, again, a type of clinical question. So have a look here, please. This is a 25-year-old lady who presents with 3 days of fever up to 38.5 degrees centigrade. She is also having sore throat and painful swallowing. The lesions are shown in the picture. The patient is most likely infected with which microorganism? Now look at this picture and describe this picture first. What can you see here? What is this? Anybody?
Sir, this is a case of sore throat. I think tonsillitis is also there because there is redness of palate and also swelling of peritonsillar pillars and also uvula. Also, I can see the pus points. So most likely can be sir Streptococcus pyogen.
Okay. So the way he is giving reason, okay, I'll consider that. Any other student want to take participation here? Anybody? Now see here. Anybody? Now all of you please see here. This is the area of tonsil here. Okay. These are tonsillar pillar actually. It is tonsillar pillar, and tonsils are not that enlarged in this case. Number one. Number two, this looks like a bit of a vesicle to me. These are a little bit blisters. Some of the blisters are already ruptured, but here I can clearly see. Okay, so tonsillar enlargement is not that prominent first, and the posterior part of the oral cavity is prominently affected here. We can see some blisters or some vesicles, some red appearance, okay, something like that. And look at the history. It is just 3 days. This is an acute type of case, okay, and very painful swallowing. So if this is shown with this type of description, then the first diagnosis which comes in my mind is herpangina. Herpangina. So what is herpangina? It is caused by which virus or which bacteria?
Coxsackie virus.
Exactly, it is caused by Coxsackie virus. Now, Aman was telling about streptococcal infection. Now, I cannot ignore that, because these are the common differential diagnosis of this type of case. If no picture was given and only this case, then definitely that is also one of the very, possible diagnosis. In that case, probably the tonsil will be hugely enlarged, and there are pus point right over the tonsil, not in other areas. The pus point will form over the tonsil itself. So this is herpes angina. Treatment is symptomatic. We don't have any specific drug against this. After 5 to 7 days, this patient is going to be better. Herpes angina caused by Coxsackie virus. Now another one, a direct question again. Which of the following is not an autosomal recessive disorder? Very easy question. So just look at this and tell me the answer. Not an autosomal recessive disorder. Phenylketonuria, thalassemia, tuberous sclerosis, sickle cell disorder, and Tay-Sachs disease. Which is not an autosomal recessive disorder? You have to pick that.
Sir, sir, it's C.
So he is going for C, tuberous sclerosis. Okay.
Yes, sir.
Okay.
Sir, because sir, we have studied that about thalassemia and sickle cell anemia, sir.
Good.
They are both hemolytic anemias and they are autosomal recessive.
Good.
And also in the another is phenylketonuria and Tay-Sachs disease from biochemistry. They are mostly metabolic and they are mostly likely to be the autosomal recessive also.
Very good reason he has given. Excellent. That's what I try to deliver in this question. Most of the metabolic disorders are autosomal recessive in inheritance. And this thalassemia and sickle cell anemia, you have studied in hematology, both of them are autosomal recessive. Very good. And only one, exception here is tuberous sclerosis. This is a disease which is having autosomal dominant inheritance. And you know something about it. This disease causes involvement of the central nervous system, okay, mainly. So intractable epilepsy occurs in this patient. So intractable means very difficult to treat with the help of anti-epileptic drug, okay. So prolonged seizure, very difficult to control seizure occurs in the patient. Patient also have mental retardation, okay. And then some of the lesion on the skin, these are called phacomatosis, lesion on the skin like ash leaf spot, adenoma sebaceum on the face, also having problem in the heart and kidney, rhabdomyoma in the heart, okay, and kidneys are also affected. So this is tuberous sclerosis disease. Remember this. So what is the point I'm trying to deliver here? Please make a note of autosomal recessive disorders and autosomal dominant disorder whenever you have time. This type of question can be asked. Now, look at this picture and tell me which virus causes this particular lesion. I'm sure 100% of the student can solve this. Which virus is this?
HPV.
Yes? Human
Human papilloma.
papilloma virus.
Human papilloma.
Very good. Human papilloma virus. Okay, anyone can diagnose it by just looking at the lesion. These are warts, okay, or verruca. Verruca are other term. This is verruca vulgaris, the most common type of verruca or viral wart. This is always caused by human papilloma virus. Now, human papilloma virus is a DNA virus. Okay, HPV is a DNA virus. This is the first thing. And this virus, okay, causes anogenital wart as well. Anogenital wart. What is another term for anogenital wart? Anybody remember? We discussed this in dermatology. Any particular term we have discussed there regarding the anogenital wart? Condyloma acuminata. Okay.
Yes.
Condyloma acuminata. Yes, sometimes when the question comes suddenly, you tend to forget. But when you see that options, then it strikes. That's why solving MCQ exam is quite easy than answering in the VIVA exam. So this is condyloma acuminata, or anogenital wart. Now, what I want to deliver here is some of these human papilloma virus are carcinogenic in nature, like serotype 16 and 18 are the important one, which causes some of the genital tract malignancy, especially in case of female. What is that malignancy I'm talking about here?
cervical
Cervical
carcinoma.
cancer.
Exactly, CIN and cervical cancer. Okay. CIN and cervical cancer. CIN is the early stage, a cervical intraepithelial neoplasia, okay, or carcinoma in situ. The third stage of CIN is called carcinoma in situ, and when it crosses the basement membrane, we call it invasive cervical cancer. This is the commonest type of cancer in female in South Asia. So whenever you are giving this oral exam or VIVA exam during your licensing process, if your examiner asks you, can you tell me the commonest cancer in female in Pakistan? Don't hesitate to say cervical cancer as your answer. This is so common in our part of the world, and this is caused by human papilloma virus. Now, immediately, what are the other cancer caused by human papilloma virus? Other cancer. Anybody? Are there any other cancer caused by HPV or not? Yes, head and neck cancer. Okay, head and neck malignancies. This is a very broad or vague term to precise that, like esophageal cancer, laryngeal cancer, okay, even oropharyngeal cancer. They are also caused by human papilloma virus as one of the causative factor or agent. Different researchers have proven that. Even penile cancer, okay, human papilloma virus is involved. So these are some of the important information. Now, let's move further. Let's see this case now. A 10-year-old boy with abdominal distension, diarrhea, and weight loss came to the hospital. So this is a 10-year-old boy came with abdominal distension, diarrhea, and weight loss. Jejunal biopsy findings are shown here. Okay, this is the jejunal biopsy. This one. This is normal appearance, and this is what is occurring in the child. What malignancy is associated with this condition? So the question is a little bit difficult here. First, you need to diagnose what is this condition, and then as a complication, which malignancy can develop from this situation? That is the question. Okay, first, what is the diagnosis here? By looking at the histopathological slide and the clinical clue.
Sir, this is a malabsorption, sir. Celiac disease,
Celiac disease.
because there is the
Mhm.
flattening of villi is there, sir, on histopathological specimens.
Good, good. So he's right. He has picked the correct diagnosis here. Look at this, comparison between the normal villi and the flattened villi. These are flat villi. The typical structures are not seen anymore, and these are a lot of lymphocytic infiltration. These blue dots are the inflammatory cells which are present in the lamina propria of the small intestine. So most probably, if I compare with this clinical presentation, okay, this is celiac disease, celiac sprue or celiac disease, a very important cause of malabsorption. Now, because of that, the child is having diarrhea, weight loss, and abdominal distension can be there because of gas formation inside the GI tract, or even because of malnutrition that can be there. Now, the question is not that. The question is which malignancy is associated with this condition. So what is the answer?
T-cell lymphoma.
Exactly. It's a type of lymphoma. Okay. It's a type of lymphoma. It's a T-cell lymphoma. So remember, this is a bit of difficult question actually. If they ask you the diagnosis, then it will be very easy. But you have to remember which malignancy is associated with that. The lymphoma of this area may occur. That is usually T-cell lymphoma. T-cell lymphoma is the answer. Now, let's move further. This is the trophozoite stage of a common parasite. So identify the parasite. This is so classical, that once you see, you can remember it all the time. What is this?
Giardia lamblia.
Optics.
Yes.
Giardia.
Giardia, exactly. This is Giardia lamblia. This is a trophozoite, phase of Giardia lamblia. Now, what type of disease is caused by Giardia? What problem is caused by Giardia?
Sir,
Giardiasis,
cause
diarrhea.
it causes two type of problems, sir.
Yes.
It's about diarrhea, sir. One is acute and another is chronic, sir. In acute cases, it causes the sudden and very much like explosive type of diarrhea. But in chronic form, it causes like malabsorption and these type of things.
Very good. He is answering in an excellent way. Giardiasis is the disease caused by Giardia lamblia. Another term for this is Giardia intestinalis. Okay, Giardia intestinalis. In some of the textbook, it is mentioned like that. It can cause two problems: acute and chronic. Acute giardiasis and chronic giardiasis. Now, acute giardiasis presents as explosive diarrhea. Okay, there is a lot of gas formation. Okay, there is a watery type of diarrhea, and this can be easily diagnosed. Actually, this type of patient usually present to the hospital, and we can do the stool examination. And the stool, there may be presence of the cyst or even sometimes the trophozoite forms of the Giardia lamblia. Trophozoite form should not be present for the diagnosis. Okay, cyst may be enough. Whereas the chronic giardiasis is all about malabsorption, and it is difficult to diagnose because patient is not that sick. So they probably may not seek the medical attention, and it is clearly causing malabsorption. So steatorrhea is the problem of chronic giardiasis, whereas explosive watery diarrhea is the problem of acute giardiasis. So what is the treatment? What is the treatment now?
Metronidazole, tinidazole, and some of the supportive treatments such as fluids infusion.
Very
IV fluids.
good. Very good. Good way of answering. If the patient is dehydrated, you give IV fluids. If the patient is dehydrated, you ask the patient to drink more fluids. Okay. If mild to moderate dehydration, home treatment, more fluid. If severely dehydrated, IV fluid in the hospital. Along with that, antibiotic is given to kill this particular microorganism or parasite, I should say, rather than microorganism. That is done by metronidazole, tinidazole, sacubitril, any those type of drugs. Excellent. Let's move on. Now, which of the following is not an X-linked recessive disorder? The similar type of question which you have just solved here. Okay, so not an X-linked recessive disorder. Now, all of these are X-linked recessive disorder except one of them. So you have to choose that. Duchenne muscular dystrophy, hemophilia A or B, Hunter syndrome, red-green color blindness, and Ehlers-Danlos syndrome. Which one you think is the correct option here?
Sir, I think it's Duchenne's muscular dystrophy.
Okay, why? There is no reason, right? Yes, if you know, you know. If you don't, you don't. In this type of questions, probably reason are not that, it cannot be given properly. Now see there, Ehlers-Danlos syndrome and Marfan syndrome, they both are similar type of disorders. They are a type of connective tissue disorder where there is hyperstretchability of our tissues or organs. So both of them are autosomal dominant disorder. Okay, now you got their answer already. So apart from them, all other which are mentioned here are X-linked recessive disorder. Okay, Duchenne muscular dystrophy is a disease which occur in child, in a male child. So this is X-linked recessive disorder. In this condition, the calf muscle or the muscle in the lower limbs are so much atrophied, okay, or sometimes they are replaced by the fatty tissue or fatty cell, and sometimes they look a bit of bigger size, but actually they are filled with fatty cell. The muscle tissues are not present there, and those child cannot stand from the sitting position. They cannot stand from the sitting position by using their lower limb. Rather, they use their upper limb, and then with the help of upper limb, they may stand. This is a highly typical feature of Duchenne muscular dystrophy. Hemophilia A or B, no need of any explanation. These are the clotting disorders which occur because of factor 8 and factor 9 deficiency. Hunter syndrome is a type of mucopolysaccharidosis. Mucopolysaccharidosis, where there is deposition of mucopolysaccharide-like substance in the different organ or tissues. And red-green color blindness is a type of color blindness, okay, which can give a lot of problem during the license, the practical license test of the vehicle or something like that. They cannot identify the true color, and there's a big problem for those drivers of or those people. Ehlers-Danlos syndrome is a type of connective tissue disorder. Let's move on. Now, number 11. This is also an interesting type of case. An 8-year-old boy has painless cervical lymphadenopathy, proteinuria, and fatty cast in the urine. Biopsy from the cervical lymph node is shown here. Okay, this is a biopsy which is taken from the cervical lymph node. What is the possible lesion in the kidney? So they have asked a little bit difficult question. First, you need to diagnose what is this condition, and then you have to think about the possible lesion in the kidney. Now, what type of cells are these? Yes?
All eye cells.
Oval eye appearance, Reed-Steinberg.
Very good. Excellent. These are all eye appearance or Reed-Steinberg cells. See here? So this is Reed-Steinberg cell. Absolutely correct. Reed-Steinberg cell. Now, in which case Reed-Steinberg cells are seen? Which is that disease? Yes?
Hodgkin lymphomas.
Exactly. Most commonly, they are present in Hodgkin's lymphoma, but they may be present in other type of condition also. But most probably, they are seen in Hodgkin's lymphoma. A bit similar type of answer, like Philadelphia chromosome. Philadelphia chromosome is seen in other conditions also, but whenever my teacher asks this question, I think about CML first. Same thing here. I think about Hodgkin's lymphoma first in this situation. Now, okay, so this is a case of Hodgkin's lymphoma. Now, your point is what this Hodgkin's lymphoma is doing on the kidney. See this proteinuria and fatty cast in urine. So probably this is a case of nephrotic syndrome. And we know Hodgkin's lymphoma can cause nephrotic syndrome as one of the atypical manifestation or presentation. Now, the question is something different. What is the possible lesion in the kidney, the histological lesion? So what are the different types of lesion in the kidney in case of nephrotic syndrome, the histopathological lesion? Can you name them? Probably your answer is there. They are minimal change disease, okay, MCD, membranoproliferative, or focal segmental glomerulonephritis, isn't it? Right?
Yes, sir.
Yes. So it is nephrotic syndrome, probably a case of minimal change disease or mesangial-proliferative glomerulonephritis. We have to confirm that with the help of biopsy. Now, another easy question. Okay, probably all of my students who are present here can solve this. Name the organism. Give me the name, please.
Malassezia furfur.
Okay, so he's saying this is Malassezia furfur. Malassezia furfur. So which disease is caused by Malassezia furfur?
Sir, it is a dimorphic fungi, sir, and this appearance is called spaghetti and cheese ball appearance. And this is the preparation of KOH mountus, sir. And the disease caused by this fungus is tinea versicolor. It's the hypopigmented patches mainly on the back side, like on spine.
Very good. Very good. Excellent. Okay, excellent. Explanation he is giving. So this is called spaghetti and meatball appearance. Look at this long, filament-like structure. This look like spaghetti, and this looks like a meatball. So there are clearly two forms I can see here. Okay, these rounded are the yeast form, and these are the mycelial form. So this is a type of dimorphic fungi. Okay, dimorphic fungi, Malassezia furfur, and then the disease which is caused by this is called tinea versicolor, a very common type of skin problem, and the people who are from the tropical countries where there is a lot of warmth, a bit of humidity, a bit of sunshine. If they sweat a lot, then tinea versicolor commonly occurs. So before we close this session, okay, and go for the break, tell me what is the treatment of tinea versicolor? Treatment.
Sir, it go away with the topical antifungal, ketoconazole.
Good. Ketoconazole or even miconazole, isn't it? Or clotrimazole, or there is one shampoo. There is one drug which is available as the shampoo form, that is known as selenium sulfide. Selenium sulfide, which is very commonly used, okay, as the treatment. Selenium sulfide. But your answer is absolutely correct. I can use ketoconazole or miconazole or clotrimazole in the place of selenium sulfide as well. Let's continue. Another case. If the deletion affects the maternal chromosome number 15, the child will have Angelman syndrome. But if it affects the paternal chromosome, the child will have which of the following syndrome? A bit of difficult question actually, but these are quite catchy question. If we learn them nicely, we may tend to remember them if another exam is having this question. So see that if the deletion affects the maternal chromosome number 15, means the chromosome number which we are getting from the mother, if the deletion affects that, the child will have Angelman syndrome. If it same thing affects the paternal chromosome, the child will have which of the following? Is it Prader-Willi syndrome? Is it Rett syndrome? Is it Williams syndrome? Is it Noonan syndrome? Or is it Fragile X syndrome? Anybody wants to guess?
Option A, Prader-Willi syndrome.
Okay, Prader-Willi syndrome. Why? Can you give a bit of thing which you know? Yeah.
Like, sir, the question is asked, sir, like if deletion of chromosome number 15 from maternal side occur, then Angelman syndrome occur. If the same thing happened to the paternal side, so Prader-Willi syndrome occur.
Exactly. Okay. Now that is quite acceptable. This is you need to remember this. There is no proper explanation, but what happens in Prader-Willi syndrome? I'm going to talk a little bit about that. Now, first of all, let's talk about this. We are having one chromosome from the mother and one from the father, because of our homologous chromosome, we have two in number, right? One from the mother, one from the father. Now, if the maternal chromosome, which we get from the mother, is deleted, certain gene from there are deleted, then Angelman syndrome occurs. Or in the other hand, we only have paternal chromosome there. Okay, that is also the case. No maternal chromosome, but only the paternal one, that is Angelman. Whereas if paternal chromosome is having deletion of certain gene, or if only having maternal chromosome in the place of paternal one, then Prader-Willi syndrome occur. Now, in Prader-Willi syndrome, the child looks very obese. Okay, the child eats all the time. The child becomes obese, and because of that, the child can become type 2 diabetic quite early in life. There is a problem in fertility, and many of these patients are infertile actually because of hypogonadism. Okay, and they are a bit mentally retarded as well. So these are the features of Prader-Willi syndrome. Other things like Rett syndrome, okay, exclusively occurs in the girls, and those girls have some abnormal type of movement, some learning disability, and some language disorder. Rett syndrome, not that very common. Williams syndrome, okay, there is a typical appearance in the face, okay, and then there is one problem in the heart in case of Williams syndrome. This is supravalvular aortic stenosis. Noonan syndrome is the counterpart of Turner syndrome in boys. Just remember this one sentence. Counterpart of Turner syndrome in boys. Though the karyotyping is not the same, Turner syndrome is 45X0, but Noonan syndrome may occur because of mutation in certain gene. And Fragile X syndrome occurs in boys. They have a larger testis size, they have larger ear size, and then they are mentally retarded. So the answer here is Prader-Willi syndrome. A little bit of more, explanation I'm giving here. Let's move on. Okay, so this is Prader-Willi syndrome. The description is provided here. You can see this later on. Okay, so most of the points I've already told you. Now, this parasite enters into the body through penetration and cause anemia. Look at this egg and give me the diagnosis.
Hookworm.
Hookworm. Okay, why hookworm? Which clue you got here? Which type of anemia is this?
Sir, it causes iron deficiency anemia, sir. And the egg is typically of hookworm, that is Ankylostoma duodenale in Necator americanus.
Good. Okay, this egg typically looks like a hookworm egg, and this is a very typical picture, okay, of a hookworm infestation. The larva of the hookworm enters into our body through penetration. That is known as filariform larva. Okay, filariform larva. This penetrates the foot area, the sole area, and enters into the body. That's why if someone is not wearing any shoes or slipper, and if larva is present in that particular environment or the soil, then only it can enter into the body. So this is a very important preventive aspect of hookworm infestation. We always ask, it is very common, in the rural side or, towards the village area where there is open field defecation is still prevalent in many part of the, world. And then the children who play there, they don't wear any slippers or shoes. That's how hookworm anemia is common in that area, number one. Number two, after it enters into the body, remember it has a typical, life cycle.
Yes.
This particular larva, isn't it? It reaches the lung. Through the lung, it reaches the GI tract, and into the GI tract, it develops into the adult worm. And in the duodenum, this is the main area for the infestation. It keep on sucking blood on the duodenum, and it causes iron deficiency anemia. Iron deficiency anemia. Now, how we diagnose iron deficiency anemia? Yes, what is the diagnosis? What investigation we do for the confirmation of iron deficiency anemia?
Iron panel study.
Exactly, iron panel study. Iron panel study, and it has got certain point here, isn't it? Or certain headings, I can say, like what is the serum iron level? 1. What is the TIBC, total iron binding capacity? And what is ferritin? Okay, serum ferritin. So these are the three things which we commonly see. So serum iron level will be decreased here. TIBC is increased, and serum ferritin is also decreased. So this is a typical of microcytic hypochromic anemia. So why I am discussing like this for so many other students? Okay, some of the students know this very well because they have prepared quite well. But for other students, the same question, okay, may have this type of option for you. Okay, so oh, I've never studied this, I've never heard this. I don't say like that. Okay, so these are similar type of knowledge. So what is the treatment of Hukum anemia? Treatment.
Albendazole, mebendazole, and for anemia, we have to go for iron supplement.
Very good. So he is including both of the things together. For anemia also, he is telling the treatment, and for the parasite also, he is mentioning the treatment. Absolutely correct. Albendazole, mebendazole, and it depends on how severe is the anemia. If it is a mild to moderate, we treat with iron. If it is severe one, we treat with blood transfusion. Okay, Ankylostoma duodenale or Necator americanus. These are the species of the hookworm. Now let's go to another case. The thigh, axilla, and face, okay, at birth is covered by a creamy white substance in many term babies like this, which you can see here. What is that substance? What is the name of that substance? This is the question. Anyone? What is this substance called? This white substance, see there? It is sticking right there on the surface of the skin. This question is from pediatrics. Anybody? This is known as vernix caseosa. Vernix caseosa. This vernix caseosa is a sticky type of substance, white in color, and this has a protective function, and that protection is protecting from the hypothermia. Okay, it is protecting from hypothermia, which may develop in that newborn. So don't try to remove it forcefully. Within 1 to 2 or 2 to 3 days, when we give a bath or shower to the baby, it will easily removed from the body. So vernix caseosa. And in the preterm babies, it is not developed till that time, and this is a very important point. Vernix caseosa. Now, another question, which is very easy for the students. See here. This is a 35-year-old patient, came to the hospital with severe pain and inability to move the right shoulder joint. So he has a trauma, probably that because of that he has severe pain and inability to move the right shoulder joint. There was history of injury while playing the football. The injury history was also given. Which nerve had high chance of damage because of this type of problem?
Axillary.
So what is this?
Yes,
You can see this on the picture first.
it's the
Shoulder
dislocation.
dislocation.
Very good. Shoulder joint dislocation. Very good. This is shoulder joint dislocation. The head of the humerus is completely out of the glenoid fossa. This is glenoid fossa. This is head of the humerus. There's no contact at all. So this is dislocation, and axillary nerve has high chance of damage in this type of dislocation. Now, what happens if axillary nerve is damaged?
Sir, axillary nerve supply, sir, its function is the rotation of the knee, like above the shoulder joint, and that muscle is responsible. Is that deltoid muscle?
Deltoid muscle.
Very good. Very good. Deltoid muscle is paralyzed if axillary nerve is damaged, and the function of deltoid muscle is abduction of the shoulder joint. abduction. Okay, abduction of shoulder. Now, after axillary nerve is damaged, abduction of shoulder is impossible. Another important clinical feature, the nice shape of our shoulder is also maintained by deltoid muscle, and head of the humerus is also contributing there. There is no doubt, but head of the humerus is dislocated, right? So because of the that the shape of the shoulder is not natural. It doesn't look like previous one. This is another important point. And teres minor is another muscle which is supplied by axillary nerve, and apart from them, a small area of the skin which lies on the lateral aspect of the arm is also supplied by axillary nerve. Okay, this is called the regiment batch area, just like the soldier who wear the batch there, so regiment batch area. So this is how we remember. This is a sensory function of axillary nerve. So deltoid muscle, teres minor muscle, and that small skin is supplied by axillary nerve. So these are the problem area. Now, another similar type of case, a newborn baby after a difficult delivery developed Wetter's tip deformity sign. So what is the diagnosis? See there, Wetter's tip deformity sign. So tell me the straightforward diagnosis here.
Sir,
Yes.
Ars palsy.
Ars paralysis, sir, because of damage done to the upper trunk of the brachial plexus.
Exactly.
C5, C6.
Exactly. You're absolutely right. Both of them. This is Erb's palsy or Erb's paralysis. And this occurs when C5 or C6 nerve is damaged. Okay, these constitute the upper trunk of the brachial plexus. And look at the typical presentation here. This is called Wetter's tip or policeman's tip deformity, both, because they just give a tip, and that is a bit of illegal thing, isn't it? Like this, so that other people cannot see. That is the meaning. So this is a very, very important question which may be asked to in your future exam. Now, usually, this type of deformity occurs during the breech delivery. During breech delivery, what happens? The body comes out first, and the head may get stuck there. So they may pull excessively, on the arm or something like that, just to deliver the head. So because of that, there is overstretching of the upper trunk of the brachial plexus, leading to Erb's palsy. Okay, see this? This is characteristic of Erb's palsy, C5 to C6 nerve damage, which accounts for almost 90% of brachial plexus injury. Now, okay, a bit of radiological question now. This patient presented with severe breathlessness and chest pain. This is sudden onset. So what is the diagnosis? Look at this X-ray and tell me. Take a bit of time, okay? What this X-ray is showing you. Anyone?
Pneumothorax.
Okay, pneumothorax on which side? Good. Yes.
And left side.
Excellent. Pneumothorax on the left side. So what did you see there? Can you explain, please?
The marking is cannot be see the marking is more dark side.
Good. Good. Now, absolutely correct. Okay, he has identified or given the correct diagnosis here. See this. All of you, please focus this. Look at this lung and just compare with this lung. So I can see a lot of marking here. These are called bronchovascular marking. And this lung, I cannot see any bronchovascular marking. It's uniformly or homogeneously black in appearance. Then another question is, where is the lung then? Isn't it? Where is the lung here? The lung is collapsed. This is the lung. Only this is the lung here. It is completely collapsed. So this is a case of tension pneumothorax on the left side. Tension pneumothorax on the left. And this is a typical presentation. Tension pneumothorax present with severe breathlessness and chest pain. There may be some history why the patient is having that. Okay. Sometimes there are some medical illnesses present in the lung, like tuberculosis. Sometimes the person is a thin, tall smoker. So there may not be any non-medical illness. In that type of person, there may be some apical blade present, and they may just rupture and leading to tension type of pneumothorax. Now, some of the discussion is necessary here. Now, during examination of this patient, what are the finding I get? Isn't it?
Hyper.
Yes. Let me ask you.
Hyperresonance on pulsation.
Exactly. So one is hyperresonance. Hyperresonance percussion note. Hyperresonance percussion note. Very good. This is one. What else?
You cannot hear the sound on the affected side because
And exactly. The breath sounds
Breath
are
sound.
absent. Very good. Breath sounds are absent.
and
Then
Tracheal shift.
tracheal deviation to the
Trac-
opposite side.
tracheal shift or tracheal deviation to the opposite side. Very good. Anything else? Any other finding?
Yes, sir. Sometimes, sir, patient present with trauma. So,
Mm-hmm. Yes. So sometimes patient
so
presents
that
with trauma. Yes.
trauma, sir.
Okay. So some
So there
features
is
of
that is
trauma
also
may be
physical.
there. Exactly. Like refracture, isn't it? Refracture, or sometimes even a bit of hemothorax. So that finding may be there. So to remember this easily, always follow the particular pattern: inspection, palpation, percussion, auscultation. You'll never forget after that. In inspection, that side of the chest doesn't move. The patient is breathing, but that side of the chest wall is not moving. This is inspection finding. On palpation, okay, I can confirm that chest wall is not moving with measurement or with some palpatory feature. Then I can confirm the trachea is shifted to the opposite side. There is trail sign present. Trail sign means the sternocleidomastoid muscle is prominent on the side where trachea is shifted. That during percussion, there is hyperresonance percussion note. And during auscultation, the vesicular breath sounds are absent. Okay, so these are highly suggestive of pneumothorax. Now, one last question before I move further. What is the management? What is the immediate treatment you like to do?
Injection and thoracocentesis.
Sir, put a wide bore needle in second intercostal space.
Good. So this is putting a wide bore needle, okay, in second intercostal space. Second intercostal space in mid-clavicular line. Never forget this. Anyone can do that. Anyone, and you can save the life of this patient if you know, if you do this actually. So just 16 to 18 gauge needle, which is easily available everywhere in the ward, in the nursing station, anywhere. You don't even need to clean the chest wall. Okay, just palpate it. We know how to palpate the second rib. We have learned that before. Okay, just approximate where is the middle part of the clavicle, just there, and puncture that area with the needle. Sudden gushing sound is heard. That means the air which is collected there under pressure has come out. And after that, what you are going to do now? Yes,
Chest tube at 6th intercostal space
very
for
good.
some time, sir.
Okay, chest tube insertion. Then only the patient is going to get better. So don't forget to put the chest tube, okay, for few days until and unless the lung is completely expanded. And some other symptomatic and supportive treatments are always necessary, like oxygen, okay, and things like that. Very good. Now another case, okay, please look on your screen. A baby was born with abdominal wall defect arising outside the umbilical ring, and the herniated bowel was not covered by peritoneum or any amnion. Exactly, you can see like this. So what is the diagnosis? What type of congenital abnormality is this?
Gastroschisis.
Gastroschisis.
Okay, so they are calling it gastroschisis. And
Yes,
it
sir.
is absolutely correct one. Gastroschisis. Now there is another term similar to gastroschisis, which is that
Yes, sir.
Omphalocele.
Omphalocele, but
exactly.
that is covered with
Very good.
peritoneum.
Very good. Gastroschisis or omphalocele both occurs because of defect in anterior abdominal wall muscle, but omphalocele has covering of the peritoneum or amnion, whereas gastroschisis is not covered by anything. So these are very, very serious type of congenital anomaly. So a bit of practical discussion again. If this type of baby is delivered in our hospital or in our center, okay, we should cover this area with warm or moist saline. Okay, warm means body temperature warmth is fine, but there should be moist. A lot of gauze pieces should be kept there so that there is no evaporation of the fluid from this area. Number one. And again, the introduction of infection is also not that common. Second, I have to start IV fluid in this baby. And third, I need to refer as soon as possible to the pediatric surgeon. These are the three things which I am going to do if I see this type of anomaly, because more type of management is not possible in our center, okay, especially if there are no pediatric surgeon. Gastroschisis. Okay, now let's move on. Another case. See here. This patient is having fever, rusty sputum, and chest pain. On examination, a tubular type of bronchial breathing was heard, okay, during auscultation. Now they have asked what may be the most likely causative agent here. Just see this and
Lobar
tell me.
pneumonia caused by Streptococcus pneumoniae.
Good. Lobar pneumonia caused by Streptococcus pneumoniae. Good. That is the answer. Any other student wants to add something, or they completely agree with his answer? Anybody? I agree with his answer. Okay, that is a very correct one. Now see here, this is a typical presentation of lobar pneumonia caused by pneumococci or Streptococcus pneumoniae. Look at this. This is the typical X-ray. Probably the middle lobe is affected here on the right side. And then tubular type of bronchial breathing is a hallmark of lobar pneumonia. High grade fever, rusty sputum means there is a blood in the sputum, and chest pain on that particular area while coughing. This is the pleuritic type of chest pain. These are typical of lobar pneumonia, and the most common agent causing lobar pneumonia is pneumococci. What is the treatment now of pneumococci or pneumococcal pneumonia? What's the treatment?
Simple penicillin or penicillin group of drugs. because they are highly sensitive to this still.
Good. So you don't need to use any other advanced type of drug here. Simple penicillin or like amoxicillin, ampicillin, this type of drugs would be enough, okay, for the treatment of streptococcal group of organism. Excellent. Now, a bit of pathological, discussion here, because that is important. I certainly remember that. There are 4 stages when we talk about this lobar pneumonia. The first stage is called stage of congestion, when everything is starting, stage of congestion. And during that phase or stage, if we auscultate the patient, there will be crackles present. There will be crackle. It's a stage of congestion. The second stage is stage of red hepatization. Third stage, gray hepatization. And the fourth stage is resolution. Now, according to the stage, the auscultatory finding is different. That's what I want to highlight here. In second and third stage, there is presence of bronchial breath sound. See this bronchial breath sound. This bronchial breath sound is a tubular type. And in the last stage, which is called stage of resolution, again, the crackles will come back. Crackles. So crackles in the beginning, okay, in hepatization stage, bronchial breath sound, and the last stage, again, crackle. So these are very typical of lobar pneumonia stage. Now, a bit of embryological question. Now, see this. In the developing embryo, the pharyngeal arches are formed. We know that there are 6 pharyngeal arch. The second branchial or pharyngeal arch gives rise to the stapedius, orbicularis oris, and posterior belly of the digastric muscle, which all develops from the second branchial arch. Which of the following cranial nerve is associated with this arch? Because each of this arch is having a cranial nerve. So which is associated with this second branchial arch? That is the question. Is it glossopharyngeal nerve? Is it vagus nerve? Is it trigeminal nerve? Is it facial nerve? Or is it abducens nerve?
D. Facial nerve.
Facial nerve, sir.
Exactly. It's a very easy question. Very easy question. This is facial nerve. And the clue for you is these muscles. All of these muscles are supplied by facial nerve. There's no doubt about it. Stapedius is supplied by facial nerve. Orbicularis oris and posterior belly of the digastric, all are supplied by facial nerve. So it has to be the facial nerve. Okay. Now, another one from the embryology again. So another interesting question. A 20-year-old woman is unable to conceive and undergoes an infertility workup. So there is a definition of infertility which may be fulfilled in her after 1 year of the marriage, okay, with unprotected intercourse. If there is no conceiving, then we call it infertility. A pelvic ultrasound reveals a bicornuate uterus. Okay, there are 2 horns on the uterus, bicornuate uterus. Which of the following is the most likely explanation for our anomalous uterus? So let's talk about the option. Excessive circulating maternal androgen while in utero, failure of primordial germ cell migration, low circulating levels of fetal and estrogen, failure of the urorectal septum to reach the perineum, or failure of the paramesonephric duct to fuse. What do you think? What is the answer here?
It's option D, sir.
Option E. E.
Sorry, sir.
Option number E.
Paramesonephric ducts.
So paramesonephric duct to fuse. That is your answer, right? Yes.
Yes, sir.
Okay. And that is a correct answer actually, because if you go back and see how the female internal genital tract is developed, this paramesonephric duct is the one, okay, which is developing that. So both fallopian tubes are developed from there, and then there is a fusion of these both paramesonephric duct, and then uterus is developed. The main uterus is developed. Then upper part of the vagina is also developed from there. So if they fail to fuse, okay, then they will develop a lot of congenital anomaly of the uterus, like uterus didelphi, okay, bicornuate uterus, septate uterus, and all those things will be there. Okay. Now another embryological questions for you. In a developing embryo, see there, in a developing embryo, the neural crest cells are formed adjacent to the neural tube. These neural crest cells then undergo migration and develop into a different structure in the body. Which of the following structure is derived from these migrating cells? Out of these all clues, which one is developing from them? Is it dorsal root ganglion? Is it dura mater? Is it epidermis covering the back area? Is it intervertebral disc, or is it sclerotome? What do you think?
Sir, dorsal root ganglion.
So you are going for dorsal root ganglia. Any other answer? Anybody else?
Intervertebral disc.
Intervertebral disc. Are you sure?
It's A, sir.
So he's also going for dorsal root ganglion, and that is the correct answer. Dorsal root ganglion. Okay, dorsal root ganglion. Now, this dorsal root ganglion is associated with which structure? Where it is present?
Spinal cord, sir. Sir, it's present in spinal cord, received all sensations, and it is continue with the posterior part of the spinal cord.
Exactly, is right. It is actually having the neurons of sensory nerve. It is having the nerve cells of sensory neuron, you can say like that. So it is connected to the spinal cord, and the function is sensation. It receives the sensation, and that sensation will go into the spinal cord. Now, dura mater, okay, is developing from ectoderm. Epidermis covering the back, also from ectoderm. Intervertebral disc, okay, is developing from the, yesterday we talked about this, if you remember, the PIVD. When we talk about PIVD, we have asked that question. Yes, notochord, okay, the notochord, the nucleus pulposus of the intervertebral disc is developed from notochord, and that's what they want to ask here. Very important question. And sclerotome, okay, this is from the mesoderm. So these are some other information, but let's talk a little bit about what are the other, cells or tissues that are developed from neural crest cells. Anybody? What are the other?
Sir,
Melanocytes.
Good. One is melanocyte. Yes.
and all sympathetic ganglion, sir.
Good. All sympathetic ganglion. Very good. Anything else? Pia mater. Okay. It is written in the textbook. Pia mater is also, derived from the neural crest cells, and then the cartilage, the laryngeal cartilage, which are there, and smooth muscles are also, derived from the neural crest cells. So, from the exam point of view, remember the melanocyte. They love to ask that melanocyte and dorsal root ganglion are the derivative of neural crest cells. Let's move on. Now, let's take a break after this, and we'll join again. The two superior and two inferior parathyroid glands are found adjacent to the posterior aspect of the thyroid gland. We all know that. On the back of the thyroid gland, we have two superior and two inferior parathyroid glands, 4 in number. From which of the following are these parathyroid glands derived in embryological development? Is it from foramen cecum? Is it from mandibular swelling? Is it from pharyngeal arches, pharyngeal pouch, or thyroglossal duct itself?
It's pharyngeal pouches.
It is pharyngeal pouch. Exactly. Okay, that is the correct answer. Pharyngeal pouch. So these pharyngeal pouches are responsible for the development of this parathyroid gland and thymus as well. Thymus is also developed from there. Pharyngeal parathyroid gland as well as thymus. Now, foramen cecum is associated with the development of which structure?
Thyroid gland.
Exactly.
Thyroid gland.
Thyroglossal.
Yes. Thyroglossal duct starts from there and later on it develops into the thyroid gland. Okay. So all others are some other choices they have given for you. Okay, then let's start again. We're talking about some clinical cases. Okay, now see there. All of the following are unsaturated fatty acids, except very easy question for you from the biochemistry. So, what is the correct option here? Is it oleic acid? Is it arachidonic acid? Is it linolenic acid, linoleic acid, or palmitic acid? Anyone? What is the correct answer here?
Palmitic acid.
Okay, that's the correct one. Palmitic acid. Apart from palmitic acid, all others are example of unsaturated fatty acid. This is an example of saturated fatty acid. Okay. Now you must have studied about arachidonic acid, some of the derivatives of arachidonic acid, like prostaglandins and
Yes.
leukotrienes. So these are the important connection between unsaturated fatty acid and those chemical mediators. Let's move on. The direct question. All of the following are examples of disaccharide. See there, another very easy question. Except. So one is not disaccharide and you have to choose that. Is it maltose, lactose, galactose, or sucrose? What is the correct answer?
Galactose.
So one is monosaccharide and others are disaccharides. So we have to choose which is the monosaccharide here because this is except type of question, right? So maltose is a disaccharide. Lactose is a disaccharide. Sucrose is a disaccharide. And galactose
sir.
is not a disaccharide. It's a monosaccharide. So what are the other, type examples of monosaccharide? Yes,
Glucose, fructose.
exactly. Glucose and fructose. These are monosaccharide, glucose and fructose. So let me write that because some other students want to know monosaccharides. One monosaccharide is given here, galactose. So the most important one is glucose, then fructose. Okay, glucose, then fructose, and galactose, which is the correct answer there. Very good. So let's move on. Now, a bit of clinical question. Look at this X-ray. Look at the picture of this child, and what findings you can see there in the picture. And according to that finding, what is the diagnosis?
Verum deformity.
Okay. So, what is the diagnosis?
Chondroplasia.
Achondroplasia. Okay. He is going for achondroplasia. Any other?
I will go for rickets
Rickets. You want to go for rickets. Why?
because sir, the typical age of the child. It's
Mhm.
rickets because of vitamin D deficiency,
Mhm.
and also the X-rays has shown that the bone deformity is typical of rickets, sir. They are widened and the epiphysis.
Good. Good. So a lot of reasons he has given. So I completely agree with this. This is a case of rickets. Okay. Look at this, swollen knees here. The child presents with that swollen knees, and these are the bony deformity. I can see even without the X-ray. Look at this outward bowing of the leg. Okay, look at the femur; it is bent outwards because bones are very soft in case of rickets. This is because of vitamin D deficiency in children, and they are usually malnourished as well. This is a typical age when they start to walk, then the bone slowly get deformed. Another very, very important clue for you is look at the epiphysis. This epiphysis is widened and there is splaying, we say. They are wide and they are, a little bit compressed. So flaying and splaying of the epiphysis is a typical feature of rickets. So in case of achondroplasia, okay, the bones are short, there's no doubt. Because of the age also the bone looks short here. These bones are not that bent like this. There's no deformity like this in case of achondroplasia. The bones are just shorter. Now, all of the following vitamins are synthesized by gut flora except another direct question: B7, B9, B12, or vitamin K. What is the answer here?
B7.
Okay, he's
Folic acid, sir.
going for B7, he's going for B9 or folic acid. Okay, so remember this B7 is called biotin, B9 folic acid, B12 is, what is the another name for B12?
Cobalamins.
Exactly,
Sorry.
cobalamin. Yes,
Yes,
you can say cobalamin or cyanocobalamin, both terms are correct. And vitamin K, it doesn't have any other name, it's vitamin K itself. So B7, B9, and B12 and vitamin K. Among them, B9 is not synthesized by gut flora, but biotin, vitamin B12, and vitamin K all are synthesized by our gut flora. So this is a important question. Please remember from now onwards. So sometimes the other question maybe, for example, I can easily give vitamin A here, vitamin D here, and vitamin E here, for example, and one of the option among them. And I can ask which of the following vitamin is synthesized by gut flora, like that. So you need to remember all the names. Okay. Now, chronic alcoholics develop this condition because of thiamine deficiency, where vision change, ataxia, and memory loss or dementia occur. So what is the name of that condition which is caused by thiamine deficiency, but it develops in chronic alcoholic people?
Korsakoff.
Both
Wernicke-Korsakoff psychosis.
excellent. Wernicke-Korsakoff psychosis or syndrome, whatever you want to say, that is the correct answer. Very nice. Wernicke-Korsakoff psychosis or syndrome. Excellent. This occurs because of vitamin B1 or thiamine deficiency. That's why, remember this important point, during the management, okay, we give thiamine and then we give glucose in this type of individuals. Without thiamine, this disorder is not going to be reversed. Okay, so at the end, I like to request you all to like the video as much as possible, share it among your friends, and subscribe to the channel so that it will encourage me a lot for the future videos and recordings. Thank you so much.